So our next presenter is, I would like to invite Dr. Gazella. Dr. Gazella Bruce, she has done her post-graduation at ESI Basai Dharapur, New Delhi, and she did her senior residency in glaucoma services at RP Center, AIMS. And she is currently working as a consultant glaucoma at LV Prasad Eye Institute, Hyderabad. And she'll be talking to us about the approach to post-traumatic glaucoma, taming the silent killer.
Good morning, everyone. Thank you, Devesh sir, for this opportunity. So, I'd like to just define this post-traumatic glaucoma. It is any post-trauma raised IOP of more than 21 mmHg, which can be acute or chronic, and after blunt or penetrating trauma, and with or without establishment of the glaucomatous optic neuropathy, and if visual field testing is possible, depending on this as well. So, of course, most data show that it is more common in males, and the incidence varies according to the study from 2.67% to 43%. And the incidence seems to be more in case of closed globe injuries, and with the increase of the years, it becomes more increase in incidence. So just to know that in cases of glaucoma, we will also see the signs of these 7 rings of trauma. We can see in these patients presence of sphincter tears, iridodialysis, angle recession is very important. Cyclodialysis can also be seen, which later on after closure can develop into post-traumatic glaucoma. And zonular dialysis with or without lens subluxation or dislocation, along with vitreous base avulsion and peripheral retinal dialysis. So in post-traumatic glaucoma, we have to look for all these other signs as well. So a huge list here showing the causes of early and delayed traumatic glaucoma. Early being inflammation, hyphema, lens-induced, or a massive suprachoroidal hemorrhage, whereas delayed can be angle recession, steroid response, and most importantly, all these ghost cell glaucoma, hemolytic glaucomas. It can also be divided into open angle and closed angle. Open angle being most importantly angle recession and the lens-induced, and closed angle will be pupillary block or the phacomorphic type of glaucoma. When we see such patients, we should of course do a proper examination at the first offset, even checking for the contrast and near vision. And also we should try to take slit lamp photos and fundus photos, especially in medical legal cases for documentation. So we do a gonioscopy. In cases of hyphema, this is usually delayed by 2 to 3 weeks. This is to see for presence of irregular pigmentation, any recession, pus, any cyclodialysis or intraocular foreign body. We can do an ASOCT because this is non-contact in cases of trauma to see for the AC depth, lens vault, and any occult foreign bodies. And UBM also a contact procedure which can be slightly delayed. This is to see angle recession, cyclodialysis cleft, the AC depth, and any occult foreign body. So we'll go through a few of the causes of traumatic glaucoma. One is uveitis, which will show up as normal uveitis, and management will be similar to any uveitis case. But also remember that if there is prolonged inflammation, we should evaluate for any systemic conditions or any occult intraocular foreign body. And if we use a prolonged steroid use, there might be high IOP in patients who are steroid responders. Suprachoroidal hemorrhage, of course, easy to identify from the signs with the very shallow AC and the B scan showing the suprachoroidal hemorrhage. Lenticular causes are also very important. If there is anterior dislocation of the lens, it can cause pupillary block. If there is posterior dislocation, there may be vitreous prolapse, which leads to high IOP, or there might be phacolytic or phacomorphic glaucoma. So angle recession, as we all know, it is due to tear between the longitudinal and circular fibers, and there is retro displacement of the iris root. So it has to be differentiated from cyclodialysis, as seen here, cyclodialysis on the right side. So this can be differentiated clinically or on UBM also, as we see the presence of the cleft on the right side. And also there might be features of hypotony in cases of cyclodialysis. So angle recession can occur following any sort of blunt trauma, and the reported frequency, depending on study, is either 20 to 94%. And after hyphema, the rate of angle recession increases. And many of these patients go on to develop glaucoma. And in some studies, it's shown that the other eye also does develop glaucoma, which shows that these patients are actually susceptible to glaucoma from the first. So two peaks of incidence are seen. First is initially after the trauma and also many years after the trauma, which shows that we should follow up these patients regularly. So the mechanism of trauma is similar for both angle recession and hyphema. Because of the contusional deformity, this leads to shearing forces at the angle, leading to the separation of the fibers. So what are the factors which predict the development of angle recession glaucoma? The poor initial visual acuity after the trauma, higher age, and lens injury and hyphema. So how do we manage? Just like open angle glaucoma only, we have to do meticulous follow-up, treat medically, and if not treated medically, we have to go for surgical procedures, starting from filtering surgeries, implants, to finally cyclodestructive procedures. Hyphema, the mechanism similar to angle recession, and these are the blood vessels which are commonly involved in the bleeding during the hyphema. So how does glaucoma occur in hyphema? It can be due to occlusion of the tubercular meshwork by any clot, inflammatory cells, or RBCs, or if the clot is very large, it can lead to pupillary block. So we try to grade the hyphema so that this helps us in the management of the case, whether we need to drain the hyphema or just medically manage it. So usually the grade 4 or 8 ball hyphema has to be treated with irrigation aspiration. So with this amount of hyphema, the severity of glaucoma or risk of glaucoma keeps on increasing, with 8 ball hyphema almost having 100% risk. Complications of a hyphema, if not treated properly, are it can lead to formation of peripheral anterior synechia or optic atrophy if not treated on time. And there can be corneal blood staining, rebleeding, and in children can lead to formation of amblyopia. So rebleeding is also very important, and these patients do have worse outcomes. And how do we identify it? There is an increase in the size of hyphema in the following days, or there is a layer of fresh blood over the older clot. And most people who are at risk are the ones who have any bleeding disorders. Corneal blood staining increases if the IOP is more than 25 mHg and if the number of days is increased. So we manage it by using topical steroids, cycloplegics, glaucoma medications, propped up position. And strict bed rest is only applied to patients who have a risk of bleeding. So immediate surgical management is in a patient who have sickle cell trait disease, or if the hyphema is very large with more than 24 mmHg for more than 24 hours, or if the other eye has glaucomatous optic neuropathy. So usually we can do irrigation aspiration, but usually the clots will be very large, so we have to do an anterior vitrectomy. Microhyphema is also important because even in these cases, the glaucoma incidence is similar to a gross hyphema. Ghost cell glaucoma can occur after vitreous hemorrhage 1 to 3 months. This is because the RBCs break down and these breakdown products will block the tubercular meshwork. So how do we identify these cases? They will give a history of trauma and there is delayed onset rise of IOP. And hemolytic glaucoma also similar. They will give a history and there will be delayed onset. So I'll just go to the last 2-3 slides. The risk factors are for development of glaucoma after trauma is advancing age, lower baseline visual acuity, higher baseline IOP, any zone 2 injuries, AC inflammation, hyphema, if there is increased pigmentation, angle recession more than 180, lens injury, vitreous hemorrhage, or any intraocular foreign body. So this flow chart is very important. As we can see here, if there is traumatic glaucoma with hyphema, we want to treat the hyphema. If the IOP is normal, we can continue with this conservative management. But if the IOP is increased, then we like to drain the hyphema, and if IOP becomes normal, we'll do conservative management. But if there is increase in IOP, we'd like to do a trabeculectomy. So in case of without hyphema, traumatic glaucoma, if the IOP and CDR is normal, we'll do a medical management, and if the IOP remains normal, we'll taper the medication over a few months. But if the IOP increases, we can either go for SLT, which is controversial, or trabeculectomy. But if there is traumatic glaucoma with increase in IOP, target IOP not being reached, then glaucomatous changes in the disc, we'd like to go for surgery. So take clinic message is that we have to diagnose traumatic glaucoma early and do a careful follow-up and more aggressively in children. But most importantly, prevention is better than cure. Thank you.
Thank you, Dr. Gazella, for the wonderful presentation and the simplified algorithm that